Welcome, everyone, and thank you for joining us today for the first inHEART webinar of 2026, entitled Expert Roundtable, Pulsed Field Ablation for Ventricular Tachycardia. We had over 200 attendees register for today's event. Today, we are joined by Dr. Ante Anić, cardiologist and electrophysiologist, head of EP Lab Heart Center at University Hospital Split, and Dr. Pasquale Santangeli, director of the VT program Cardiac Electrophysiology and Pacing section at the Cleveland Clinic. In addition, we are joined by guest panelists, Dr. Benjamin Berte, cardiologist and electrophysiologist at Hirslanden Clinic, Santa Ana, and Dr. Anish Tolat, director of the VT program at the Hartford Healthcare Heart and Vascular Institute. My name is Kristen Lomas, and I will be moderating today's conversation along with my colleague Isabella Poravecchio. We will be recording today's discussion for use online and to share with clinicians, so your continued attendance on this call will serve as consent to the audio and video recording and its distribution. Our format for today will include two presentations followed by Q&A. Attendees, we encourage you to submit questions via the Q&A feature at the bottom of the screen, and we will work them into the conversation. Before we begin, please note that PFA for VT is currently investigational and has not been approved for this indication in either the United States or the EU. The content presented today is for educational purposes only and should not be interpreted as promoting an approved use. We have a lot of content to cover, so let's get started. Dr. Anić, we will start with your presentation.
Thank you, Kristen. Hello, everyone. It's my pleasure to be here. And I was asked a few months ago to share some experience with pulsed field ablation for VT. And let me do that. They're my competencies. So when we talk about ventricular arrhythmia and PFA, it definitely holds a promise as still it's investigational tool. However, I know that EPs don't feel comfortable ablating in ventricular myocardium with strange geocathode platforms. We also have to understand that it's a more complex architecture on a myocardial level. So don't count that what works in atrium for a given PFA will work exactly in V. If you want to simply titrate up or crank up the energy for the PFA configuration that works in A, it would result in an unacceptably wide lesion. In order to get 10 millimeter depth, you would probably go like 25 millimeter wide, and this is unacceptable. This is probably what we aim for. You see here from the cardiac level, you see clear, narrow lesion. It goes very deep. It can go deep, down to 20 millimeters. But again, you really desire this, and does this comes with a safety for the blood, for the surrounding structures like his Purkinje system or vessels? That has to be well studied. And we have been very bad in translating lesion formation science in atrium from animal lab to the clinical medicine, and let alone, we're gonna bump to more problems for ventricular arrhythmia ablation. And that having said, our first experience for ventricular arrhythmia ablation came with a so-called Galaxy Medical project. Now that needs cardio focus. So it's a pulse field ablation generator that you connect to your favorite contact force sensing, 3D mapping enabled, commercially available catheter. So as soon as we launched this system in 2022, and as soon as our guests were boarding the plane, we started to explore this focal pulse field ablation opportunity for other indication than atrial arrhythmia ablation. This is a case series report of transcoronary sinus pulse field ablation for WPW. That's something that we still very love. We started exploring value and utility of pulse field ablation for assessing acute effect on radiofrequency ablation on your GPs during cardio ablation. And of course, we definitely wanted to start using pulse field ablation for ventricular arrhythmias. This is our first case report of failed RF ablation deep in coronary sinus break cardiac vein, and it was so refreshing to deliver energy over there. Of course, minding the spasm and doing the nitro story and taking care that you don't do spasm circumflex of the LAD. Also, we found a niche that using this pulsed field ablation with this platform, it's less contact force dependent. So let's say in papillary muscle cases where you struggle to have do more than 5-6 grams, it worked well for us in the beginning. Again, despite all the imaging we could get, despite all the help that 3D imaging can get you, still it's very important to have something that we can reliably deposit energy into the tissue. And I can tell you I was really waiting that period that we start doing RVOT with pulse field ablation because none of us like having a 23-year-old girl, 60 kilo, and doing RF, aggressive RF in RVOT. I think we all were scared to death, of this indication. And as we started, and this is a publication that we did last year, these are first 23 patients followed for at least or for average of 1 year, and we had very pleasing effects using this platform for idiopathic arrhythmias, mostly for RRT, but then we have some other substrates. During this experience, we have observed something that I've really look forward to discuss during discussion, and this is like Domenico della Rocca group. They published that during idiopathic PVC ablation, they noted that 55% of your patients during immediately after PFA or during the procedure develop some ventricular irritated firing. It usually subsides after a while, but that's something that you have to take into account when you plan the procedure and perform the procedure. Please take care that also they published very pleasing long-term success rate. And we teamed up with other 7 centers, and to form Pulse PVC Registry. So it's accepted for publication in JACC-P, and this constitutes the largest report on pulse field ablation for ventricular arrhythmia. It's 200 consecutive patients treated with Centauri PFA system across 8 European centers. Of course, the outflow tract was most common anatomical site for ablation, and it was still the prevalence of coronary sinus as a route to approach these substrates is still very common in 20% of patients. I cannot tell you more. Obviously, we have to do this publication, but I can tell you that we have for now right now sufficient data about idiopathic arrhythmias. What about VTs? What about structural heart? For us, it was very encouraging to see Piper report. They did Centauri PFA in ventricle, and after a few days, patient got a new heart. And they proved that in post-SBRT scar, this technology could create 8 mm deep lesions. This was very encouraging. Well, but then when we talk about structural heart VT, we really have to know about our substrate. This is a recent case where we're warned by pre-procedural imaging that we're going to have very complex septal basal septal scar. And what we know now, it's good to have this dual energy option, because if you want to preserve a his system, many of these substrates are close to a conduction system, and this is where we like to titrate RF instead of PFA. Yes, some PFA platforms have PFA dosing options, but full dose PFA will never be as safe as we believe, close to a heat system. So knowing your substrate gets you better prepare your energy source, your options are there. And of course, imaging, let's say in this patient, we're warned that there is a nice coronary sinus branch with which we can approach this lateral substrate in this patient. So get to get the imaging work for you, and and get the best advantage of your current platforms. When we talk about multipolar catheters, and I would like to spend a minute here. Initially, of course, it's anecdotal. Just 2 German centers reported three patients into whom they did pentaspline PFA. And here I would like to point out to Pasquale's Pasquale group recent publication, where really they showed they used pentaspline PFA catheter that was never imagined to work for doing an ablation of ventricular myocardium, but essentially they did it as a bailout in patients in whom who failed the RF on a patient presented with a VT storm. Coming to the VT storm patient, I want to round up my presentation with a recent case report. This is a patient we treated around 6 months ago. It's a patient that had large myocardial, anterior myocardial infarction, and he has been, he had bypass surgery. He has door operations or resection of aneurysmectomy. And still, years after, he developed very bad, heart failure, many VTs. And he came back. He came to us. He came to us in a VT storm in October, and we opted because we saw that we can do the traditional approach. But then soon as you enter that heart, you start initiating a lot of VTs. For this patient had to be shocked several times for this unstable different morphologies, and then we went we converted to something else because if we don't want to put this patient on circuit support and make a lot of instrumentalization of this patient, we wanted to do rapid scar homogenization. And so we went on with a large footprint PFA. This thing is not designed for this idea. However, in this case, it worked well. We did a scar homogenization with a pentaspline catheter. We opted to apply in four applications. Usually we apply four applications at a single site. In this case, we applied in 4 to 5 application sites. And using our best abilities to drive this catheter transeptally with its proprietary steerable sheet, and it was wonderful. As a result, we are able to corner all those VTs to a single morphology, and as the single morphology was mapped and ablated in a regular fashion with a focal dual energy STSF catheter. And we searched across the scar, we refined our results. But based on the pre-procedural imaging, we also added, no matter we didn't have signals in some intrinsic channels, we also added what we would add anyway. And this is how it. So this is the combination of what seems like a lasso. Lasso shadow is essentially positions where we ablated with pentaspline, and we added also RF and PFA. It was wonderful to see our patient recently for follow-up. He showed up with no ventricular arrhythmias after that VT storm hospitalization. So I want to summarize and give podium to Pasquale and later on for interesting discussion. I hope PFA is not ready for a prime time, but we are getting there. I think focal catheters will be a weapon of choice in most of the cases. Multiple Russell will be attractive for some specific substrates, and I can go further and lament about this in our discussion. What I've just this case I've just shown. I think there'll be more tools like we have Field Medical focal catheter that can do very wide lesions. I see definitely utility for this kind of wild PFA platforms. Solid tip of large focal. The jury out's there. I look forward to Pasquale's lecture to see how a large focal can be used. Platforms should be developed and tested specifically for dosing and or options for lesion volume and lesion shapes in ventricle. And many substrates, are in the positions where we don't have this opportunity to toggle between RF and PFA. Like for our initial experience, that PFA really doesn't work in the aortic root above the semilunar valves. Coronary sinus, especially something that you want to use PFA, and then you're near the system, the coronary conduction system, you want to use RF mostly. So with that, I thank you for your attention and looking forward to the discussion.
Okay, thank you, Ante. I always love to look at your presentations because you're one of the pioneers trying out new stuff. I have a question for you about these deeper lesions. We know that if you go for more kilovolt or more voltage, we all, I think in the panel, expect more complications. The image that you showed, can you comment on that? For me, it feels a bit that what you did is thermal. What I see there, and we all know that PFA is non-thermal or minimal thermal, and if you start pumping up, and especially with these smaller focal, we can get into the thermal range. For me, what the image that you showed, it looked a bit thermal. Can you comment on that, please?
Benjamin, if you reference this to the ablation in post SBRT scar, when you see dark red cores of the ablation, that's an area of capillary leakage. The force, PF is so dense there that you induce capillary leakage. There's no thermal coagulation necrosis with this particular platform. But I fully agree with you that many PFA options are there are have some thermal footprint. We know that some of the complications observed are probably due to the footprint. Most of the microbubbles that we see today across various platforms that show up are definitely thermal. We know that there are various mechanisms. It was described well with Damian McClatchy's group. That we have, let's say, 3 mechanisms of how to create microbubbles, but most of them are thermal. So yes, I would be scared that in future the thermal footprint will be something a hurdle in developing pulsed field ablation for ventricular arrhythmia, especially as we strive to get deeper lesions. I agree with you that many of the platforms will have some of the thermal footprints.
And one of my most important questions here, together with the one, how do you use imaging for a PFA, but I would take that one for in the end. Are we really sure that PFA is less contact force dependent than RF? Because I have the feeling it's the opposite. I have the feeling that RF is forgiving because of the thermal latency. It's still a little bit heated up the tissue. So we have these moments, if you even, especially the contact force in the ventricle is much harder than the atrium. We both agree on that. There's multiple papers. I have the feeling, and that's why I was a bit surprised by your data on the pentaspline. I can perfectly understand the acute situation with VT or VF storm, the perfect tool to gain time. The durability of these lesions, they surprise me.
Benjamin, thank you for this question. So first about pentaspline, essentially when I saw the first report about using pentaspline ventricle, I said, okay, good luck, guys. You will have this patient soon back. But with pentaspline catheter, if you put repetitive up to 4 repetitions at single split, you can go deep. If you have good contact with pentaspline platform, you can go down to 6 or 7 millimeters, which happens to be enough in an aneurysm. Let's say if you have an apical aneurysm, then 6 millimeters is enough usually. Or in most of these channels, now that we know with using inHEART, are really where ventricular myocardium is not a thick. And coming to a story, which is, I think, very important. And let's go to the action. So contact dependency. It varies across the platform. So we do have publication that with almost the same catheter, which happens to be Navistar. Let's say with the solid tip. Let's go on it. So we have 2 different PFA generators, 2 different PFA configurations. With one, when you have 10 grams and above, there's no gain in the depth. With second, and we know this from last year Nakagawa paper and then on Luigi Di Biase and Nakagawa work, then as you go up to 40 grams of pressure, that your pulsed field ablation rate goes up. So the contact dependency is not the universal feature. No contact, no lesion. Especially with unipolar. So with a solid tip, no contact, no lesion. However, different PFA configurations and generators will show you varying levels of dependency on the contact. So I'm sure about that, and we have publications both, let's say, for this Centauri generator and for TruePulse.
Okay. So in the interest of time, I think we will go on now, and then we will have questions for all of us. Thank you.
All right. Good afternoon, morning, everyone. So here, let me see. Can you see my slides? Perfect. Okay. In presenter mode, right? So you can see the full screen. Perfect. All right. So the next 15 minutes, I'll discuss about what we learned here. With our experience in the US is more limited because we got access to PFA much later than Europe. So we're learning as we go. But we've done some key, I think, important preclinical information for VT that applies to VT ablation and PVC ablation. And also I'll discuss our early experience. I have no conflict of interest for this. And so the question is, what is the need for PFA in VT? These are old studies. Here in red, you see the VT recurrence rate for all the studies, observational studies after the failed drugs. In blue, in the more early ablation, some early studies, some done in Europe, some in the US. But the bottom line is that we still struggle with about 30 to 50% on average recurrence rate for VT. And even in the most recent studies, on the left, we have Partita by Dr. De La Bella's group, and on the right, the post-sudden death by Rotang done in Asia, where still you can clearly see there is room for improvement for ablation outcomes. And the question here, the big task that we have to answer, is whether this improvement is needed because of issues with lesion depth versus better mapping. I'm still not clear to me really which way we should go. Probably should go both ways, really, improve mapping and improve ablation. But of course, ablation efficacy, we do know there is a problem. And this is already highlighted by Dr. Ante in a very elegant way. But here I want to point out that, of course, in heterogeneous scar tissue, radiofrequency ablation is less effective, less predictable. The other big problem with RFA is because of the long applications that are needed and obligatory high rate irrigation. In patients with advanced heart failure and large substrates, this is a problem, really. And of course, there is the issue of a thermal injury to the nearby structures, coronary arteries, nerves, and so forth. So now with the Sphere 9 catheter, which is a lattice tip catheter, 9 millimeter in diameter, is able to deliver either radiofrequency ablation or pulsed field ablation. There was an animal study that was done here where in an animal model of anterior MI, radiofrequency ablation with standard thermocool catheter with a ablation index on 900, 30 watts, 21 grams on average, and 6% impedance drop. In SCAR, you barely reach 3 to 4 millimeters on average in terms of the lesion depth. And really, this highlights how limited is radiofrequency ablation for this type of substrates. Whereas on the left side, if you do apply pulsed field ablation, and this is a monopolar biphasic platform, the Affera Sphere 9, was able to jump through pre-existing scar and create nearly transmural, most of them are actually transmural lesions. So it seemed to be better than radiofrequency ablation to penetrate scar substrates. Even in models of repeat ablation, so we will get a series of patients now, a lot of patients that failed prior RFA with conventional small tip catheters. What if you do apply PFA on top of it, of the prior failed RF? There was a study where it was survived swine after radiofrequency ablation. We reablated on top of the same lesion with radiofrequency with either PFA or RFA. If you repeat RFA on RFA, the lesion gain is really minimal. But if you go with PFA on top of chronically ablated tissue, the lesion depth was significantly deeper, I would say, and more consistent. So it seems to be in a redo environment, PFA may also win over repeating RFA. And finally, this was a study that we did particularly for specific regions in the left ventricle that are implicated in PVCs, the septum, the papillary muscle, the Elvis summit via the anterior vein here, and the epicardium. Uniformly, this was a randomized study. 10 pigs were randomized to RFA or PFA in these regions. If you look at the papillary muscle lesion depth, at the Elvis summit lesion depth, and epicardia, they were all deeper, significant radiofrequency ablation. In terms of safety signals, we found more pro-arrhythmia with radiofrequency ablation in the pub muscle in swine. Again, this is 50%, is a very high rate, and maybe because of the swine model, we don't see that in humans. But definitely, we do know that pro-arrhythmia in the pub muscle area with radiofrequency ablation is a problem in some cases, some human cases, and PFA, we have not seen that. In the epicardium, on the other side, we've seen evidence of ST segment elevation and depression, so some changes in the EKG with PFA. And in this study was interesting because we have not ablated anywhere close the coronary arteries on purpose. We were more than 1 centimeter away. The coronary angiogram didn't show any evidence of epicardial macroscopic spasm, but still we saw differences in ST segment elevation and depression, most likely related to microvascular spasm that we didn't appreciate on coronary angiogram. So it's still something that we need to understand better with direct epicardial application of pulsed field ablation. Some examples here. Radiofrequency ablation on the papillary muscle, we know is very limited because of stability, because of contact over time, but also arrhythmogenicity in these cases. With PFA, we were able to deliver much more uniform and deeper lesions. Here in the Elvis summit, PFA always outperformed RFA. In none of these cases, interestingly so, we didn't find any spasm in swine, which is in keeping with what Ante has shown for the European clinical experience, where Elvis summit PFA seems to be fairly safe in terms of risk of coronary vasospasm. Of course, larger numbers are needed. But here, if you look at the RFA lesions, really 50% of the lesions were not visible. The remaining 50% were visible, but were significantly smaller than PFA. And we found no difference between the type of irrigant here, half normal sealant versus normal sealant in terms of the lesion depth, which is different than what's shown by other groups in the past. So back now to the clinical realm here. In the 2026, these are the two major companies that we have really where we can consider PFA in the ventricle. Now, recently we got approved for the point catheter. We don't know how well that performs. But commercially, we had either the pentaspline PFA, which is a biphasic bipolar system you're aware of, or the Sphere 9, really. It's a 9mm diameter lattice sphere. Is a biphasic monopolar application, smaller caliper, 8.5 French, but importantly, is able to deliver either PFA or radiofrequency ablation. Pentaspline was approved before Sphere 9, and that's why initially, this Ante already shown this data, we worked with this type of platform for large substrates that we knew that we couldn't target efficiently. Typically, these are large apical aneurysms or areas in the RV that were with extensive substrate like ARVC, for example, or failed PVC ablations most of the times from the papillary muscle area. The mean follow-up was 6 months, and again, there was encouraging findings in terms of the outcome, but again, very small numbers. What we learned from this is that all of these cases were done, of course, with a transeptal approach. We always open the basket or flower within the left ventricle, right ventricle, but we never recaptured it, because if you do recapture, you can snare out the mitral valve apparatus or tricuspid valve. We always pull back in the atrium and then we recapture it when it's floating. Of course, it's a non-steerable, it's an over-the-wire design. I mean, we don't really like to use it. So it's only helpful in the mid-apical segments, RVOT, potentially pub muscle. But in most cases, we have to touch up with RFA to complete the substrate ablation. But we were able to ablate the substrate in a fairly efficient way with less irrigation. So the touch-up ablation was only minimal. One key question is PFA transmural? And this was something that came up in the animal studies, that it may be transmural, maybe definitely deeper than RFA. I'm not so convinced about it. In this technology here with pentaspline, we had a fully epicardial VT, as you can see the map on the left. You see in green the epicardial signals here, which is from the decanav in the RVOT free wall that cover the full cycle length. So what we tried here, okay, maybe we can ablate anatomically opposite with PFA and maybe reach the epicardium here, so we don't need to go epicardial in the future with this. So as you can see here, we have ice here that shows contact with the RVT free wall. There is a wire and the PA here. And these are the signals in the endocardium. By the way, we entrained from here. This part of the circuit was not really critical at all. So it was just like pre-systolic, not even like, I would say systolic, but they had nothing to do with the active circuit. The interesting thing that we found here is that if you apply PFA there, you terminate VT effectively, if you can see the top slide here. But when we looked at the electrograms after VT terminated, the epicardium was still in dissociated VT. And again, we also moved out the QRS with adenosine here. You can see the epicardium still in VT, something that we are used to see in the pulmonary veins in the radiofrequency era with pulmonary vein firing continuously. So this was an interesting finding because number one, we could disarticulate the epicardium from the rest of the left ventricle and right ventricle just with PFA. That's number one. But number two, I would say that definitely this did not reach the epicardial surface because here the electrograms were still completely intact and the EVT was still going. So we told us that with this technology, transmurality in the RVOT free wall here was not achieved. Now, maybe monopolar PFA is better in that sense. It was a very early study. Actually, it was not a study, it was a compassionate use case, actually, that was referred to us after 3 failed endocardial ablation. He had a recent bypass surgery less than 6 months beforehand. So going epicardial was not possible, not even surgically because of high risk of bleeding. And here the problem was that there was a large inferior substrate with relatively significant wall thickness here, but you can see the echogenicity extends underneath the posterior medial papillary muscle, so it was impossible to reach from the endocardium here. And the bottom right, you can see inHEART reconstructions of the scar with CT late iodine. There was a fairly dense aneurysm in the inferior wall, but again, the wall thickness was still relatively preserved. So there, when we start mapped this case here, was an incessant BT, about 110 beats per minute. And the only interesting electrogram we found was site number C, right underneath the papillary muscle. You see this blunt, very far-field pre-systolic electrograms here that we could see. That was the best site that we could find. We couldn't capture from here, it was already ablated. But pulsed field ablation terminated this VT here, and it was not inducible afterwards. When we repeated the CT scan afterwards, there was suggestion of transmurality of lesion with late iodine after the ablation. So we're very happy that maybe in scar tissue in humans, what we found in the animal lab can be translated also to humans. Maybe we don't need to go as much epicardially in the future with this type of technology, or maybe not needed at all. I'll show you later some cases where clearly that's not the case for every patient. But here, this was an important study from Europe, was published in Europace recently, and Fred Sacher was the first author here. I think it was 18 centers, 126 patients, and you can see the usage, which is very consistent with the way we use it. So these are really used mostly for complex cases. I'm not showing you the clinical features. But most of the times when you use this catheter, you end up using both types of energy, RFA and PFA. And there are some epicardial cases. Here, this was a fairly high-risk population, but still, the results were actually acceptable. There was a 5% rate of death and transplant at about 6 months, which is really on par with prior studies. Recurrence rate was still like about 30%, but again, it was a very sick population. There are some important safety signals that came from this study. I think these two thromboembolic events are important to note here because it's something that we need to keep an eye on. We're not used to see much stroke with VT ablation clinically, really. The event rate is anywhere reported between 0% and about 1.2, 1.3%. So I think this is something we need to keep an eye on. Maybe it's the radiofrequency related. Maybe it's PFA, something to do with it. We don't know because most cases were done with both catheter platforms. But here, in one case, there was a chordate rupture because the catheter manipulation around the left ventricle, and the catheter can get stuck within the chordate, really. That's why we have not used the retroaortic approach for any of our cases, because the only way to resolve entanglement of the sphere 9 against the mitral or tricuspid valve apparatus is to recapture the sphere 9 within the sheath, exactly like we do for Watchman device. You have to recapture the sphere, and by doing that, you can free it up from the chordal apparatus. So we'll present this data, full data at HRS, and manuscript should come probably at the same time. But here, the sphere 9 was approved about a year ago, and we used it in about 18% of our cases. We selected typically patients with large areas of scar, that we know there was a large substrate, or for redo cases. All cases are done with transeptal approach. Typically, the way we use it, we use radiofrequency ablation first for all cases, just because it's easier to interpret electrogram elimination, but most importantly, VT termination with radiofrequency ablation. We don't know how specific it is with pulsed field ablation. Of course, a PFA was reinforced in case we needed a deeper lesion, or whenever we were epicardia, we always use pulsed field ablation because we're concerned about the bleeding for all around the sphere with radiofrequency ablation. So how do we use PFA? We look always at voltage, number one, but really we're looking at dense scar here with a bipolar voltage less than 0.5 millivolt. But most importantly, we look at intracardiac echo, make sure there is wall thinning and there is no contractility. Here is where image integration, I think, plays an important role because we're concerned about ablating PFA on the border zone where it can create acute stunning and potentially LV dysfunction. For intramural substrates, we always do both radiofrequency ablation and pulsed field ablation, always focus on the areas of hypokinesis or no wall motion, because again, we are concerned about the effect on the wall motion. So how transmural is this? Here we have several examples. This is one of them where is really sphere 9 is not, at least with the current iteration, is not able to deliver transmurality in a variety of different non-ischemic cases, but also ischemic. Here I'm just showing you non-ischemic. This is an example of where we see where epicardially we have a full circuit, which I'm not showing you here in the free wall of the RVOT. There is only just a voltage map. Each one of these lesions is a 4-stacked PFA, which maximum depth. But when we map the endocardium opposite to these lesions, here the lesions are epicardially, the electrograms are completely normal. There is no evidence of attenuation, no evidence of change. And here the wall thickness were probably 3 or 4 millimeters at most in the RVOT free wall. So in this case, like any other septal case that we ablated the LV septum, and then we mapped the RV septum afterwards, we have never found evidence of transmurality. So it is something that is important to note because with this technology, epicardial access is still important, at least with this iteration. And also probably we need more refinements of the PFA recipe for this to make it deeper when necessary. This is another extreme case where we are ablating the LV septum here with PFA, and we have an intramural octapolar catheter. You see here is a bit of a busy slide, but you see in purple a late potential here within the intramural space. We ablate with PFA right opposite to it. We complete our PFA application. The late potential is exactly the same, no change at all. So it didn't reach the intramural space either. So, And the other caveat, when you start mapping with this platform, if you go epicardial, particularly when you start mapping non-ischemic with basal substrates, where pericardial fat may be more represented, this is almost invariably, we found this in about 4 cases at least, so roughly 40 to 50%, we've done about 10 epicardial cases already with this technology, where epicardial fat can be clearly seen within the sphere. And of course, what is the implication for this? Clinically, it is not we haven't not seen a complication because of that. But if you use the same catheter to then remap the endocardium, then of course there is risk of embolization. So practically speaking, we always want to change with a new catheter in case you have to go back endocardially. These are only 3 months follow-up. The 6 months extended one with more information will be presented at FHRS, so it's embargoed. But here I'm showing you 90 days. We have fairly good outcomes with that. Again, these are selected patients with large substrates and redo ablation. And for the PVC ablation group, we have suppression in all of them. So I can conclude here that the dual energy RFA and PFA, which lattice catheter for a clinic has been used in roughly 18% of complex cases mostly. Far away was used in the early experience. We don't use it any longer now with Affera being available, but typically for large substrate homogenization. We prefer this type of technology for complex patient population, large substrates, repeat ablation procedures. The short-term safe efficacy and safety profile appears good, but extended follow-up and more information will be presented at HRS on Sunday, so stay tuned. And lesion depth is still suboptimal, and we do need more optimization of the waveform to reach deeper substrates. Thank you for your attention.
Well, that was a great presentation, Pasquale. Thank you so much for sharing all of that data. I had a couple questions, 2 questions, just off the top of my head. One was, you've done some animal work, some preclinical work, looking at the effect of PFA. And we've all heard about the issues around coronary spasm, but also coronary injury. And has anyone looked or cross-section through the arteries at the intima or the inner lining of the coronaries? Have you looked at any of that? Has anyone looked at some, because of late deaths?
Yeah, we have not. I think the changes maybe happen in a dynamic fashion within the first 15 days to 1 month. So really we need a survival type of model, but we have not looked at histology ourselves. There is some data from UCSF that looked at that, and there is some intimal proliferation and even early, I guess, stenosis that you can create with that. And there's an OCT study, a bit controversial, I think, coming out of, I believe, Asia, where they did OCT for in the right coronary artery, right opposite to the CTI area where they ablated with PFA, and we're all aware of that data there. I think the jury is still out. The problem, we have not done any of this type of studies with RFA. We just went in and ablated. We never investigated as much the coronaries with the radiofrequency ablation. I'd be surprised if we find no differences. In other words, I think when I ablate the CTI, we're right on top of the coronaries. I'm sure if we did OCT in RFA cases also, we will find some changes. But what really scares me, and something, my question for everybody really, is the issue of this late spasm. Where in VT population, that will result probably in VF afterwards. We have not seen a single case of it. We've done probably about 150 cases now with PFA. Maybe we haven't done enough. So, but in AFib, I don't fully understand the mechanism for that. So, and when we don't understand the mechanism, we cannot prevent it. So that's something that scares me still, and we need to understand better why that happens, if it's true that it happens, and then how to prevent it. So these are the One more thing I might say, if you don't mind, one thing that I missed in my presentation, if we do apply PFA close, another new risk that we found, close to exposed conductors of devices, pacemakers or defibrillators, you may essentially shut down the internal circuit of the defibrillator device, which ends up needing a generator change. So the critical distance that you can ablate safely, we don't know that what is there yet, honestly, and that's still a matter of debate and investigation. But that's another thing people have to be aware of.
Yeah, actually, that was going to be my second question. I was there in the audience when you talked about this at the VT symposium. But could you share with us your thoughts about the monopolar and bipolar? I mean, these technologies vary depending on the manufacturer and the catheter. You know, is monopolar a little bit more at risk, or bipolar, or we don't know? I mean, what are your thoughts about safety and devices? And
we have actually, we looked at this in two different ways, and also FHRS will be reported. The first way would be our own experience with far wave, essentially in patients with devices with SVC isolation, which we are close to devices, to leads really. And then with PFA, with Affera, we had one case of failure, which was my case that I just mentioned. So anecdotally, we've done much more far wave than Affera. So the fact that we had already one with Affera makes me think that maybe monopolar is more prone to this problem, just because the current flows to a ground electrode, and if the lead of the conductor is on the way, you will shunt some of that to that. The second issue is, the MOD database, which we looked at, is all self-reported, and that's going to be another like abstract we have. It seems to have a slightly higher prevalence of Affera cases there. If you look at the country risk of device interaction and malfunction afterwards, compared to the bipolar platforms. So maybe bipolar is safer, but I really don't have a conclusive answer to that question.
Thank you for that.
Oh, okay, Pasquale, I really enjoyed your presentation as well. If we talk about transmurality, we use PFA. When we started using it was for safety and maybe efficiency in the atrium. For the ventricle, we all agree, I think we want to improve our effectiveness first. These are sicker patients. What are your thoughts about this Verma paper and also Sauer saying this RF preconditioning using dual energy, when you use heat, that you can go much deeper? Do you think it's a safer way than to avoid complications of just increasing the voltage of PF? So that dual energy is probably where you have to put your money?
Yeah, I read the papers and I saw the data, okay? But then the explanation was not really clear why that would happen. So in other words, I don't fully understand why applying radiofrequency ablation or cryo, one or the other, then PFA will be more effective afterward. I think that needs to be a little bit more replicated, honestly. The only thing I could think of, if you apply, the heart is a semiconductor. So if you lower the impedance with heat, so if you heat it and the impedance gets lower, then if you apply PFA when the tissue is still hot, maybe, I would say maybe, PFA is more effective because you have more energy penetration. There is one caveat to that clinically speaking with Affera, for example, if you do RFA, then you got to wait until the temperature goes below 141 degrees before you can actually do PFA. So it's always like, cool. We have not really been able to do it clinically because PFA doesn't allow you to deliver when the temperature is too high. So maybe yes, but it's an interesting thing to think, but I don't know whether that's true. And the question is to what extent you gain really depth on lesions. So
there's a question. I'm sorry. There was a question in the chat here. Is maneuverability in the pericardial space with a larger catheter like Sphere 9 more difficult? Do you need to add more fluid? Is there anything you're doing to accommodate that?
I know that Katzner's group has been really including like 100, 150 cc's of saline to facilitate movements. We have not had huge issues with moving around. There is an issue of electrogram quality in the pericardial space, I would say, where there is a little bit more noise from motion, so which can affect the annotation a little bit. But moving around is not really, the problem is the map, right? I don't know if you're familiar with, I am unfortunately with Orion in the pericardial space when I tried, and I always kind of like, I wasn't very happy about it because when you expand that catheter, it creates a shell inside and an outside shell. So all of a sudden, we have to start looking at the pericardial maps from the inside, which is really not the way we've been doing things with linear catheters. So it's a little bit different way. I think that we work on the software to make the map more appealing for us, but it's not been a big issue. Now, whether you ask me the electrograms fidelity and resolution, I don't think it's as good as the multipolar catheters, not even close to what we have with HD grid or Optrel, etc. So it's more like in between a thermocool and a multipolar catheter. It's kind of like a lens in between the two in terms of fidelity and resolution. But usually it's good enough because the ablation tool is so much better than what we had that overcomes those limitations.
So Pasquale, you already mentioned that VT termination during PF ablation, because it's a kind of entrainment, is not a good endpoint anymore. It can just be chance or somewhere near the system. My main question is, I'm a bit surprised that we see so little VF because it's not gated using these systems in the ventricle. Because if you pace with your PF signal exactly in that T wave, why do we see so little VF? And it's a question for both of you.
Yeah. So couple of things about that. I mean, I have my ideas. This is really not none of this stuff that I'm going to say is proven. Okay. So, but when they, for example, for Affera, when they designed the ventricular waveform, they delayed the interpulse timing, because in animals they found if they use the HL dosing, which is 210 milliseconds, they go in VF because you burst space wherever you are, and you go in VF, you capture 1-to-1. Now, for VT, they went to 350. I kind of disagree with that strategy, because really what happens with 350, you're more likely to induce VT in scar, actually, because you can capture 1-to-1. So I've been shortening more and more the interlesion distance, because the refractory period is shorter. So it's very unlikely to capture 1-to-1. But going back to your question, why when you apply on top of the T wave, you don't induce VF? My feeling is maybe you're applying so much energy that you're above the upper limit of vulnerability, where a shock does not induce VF. Just like when you do a shock, synchronized shock on the T wave, you really induce VF only if you are below that, I would say, ULV margin. And maybe with these high volts that we deliver, we are above that. And that's why it counts exactly as a local defibrillation, where it doesn't induce VF, and I can also terminate VT. The endpoints is a problem. It's a huge problem. I think we don't know what VT termination means. We don't know what, and therefore we don't know what non-inducibility means, because it can be only transient effect. We don't know what electrogamma elimination means. We don't know what lack of capture means. So I think all of these studies we've done in the past about endpoints for VT ablation need to be revised, because none of the acute endpoints, I think, works unless you have some. So I've been taking patients at 3 months back now to do inducibility test, because we don't, I chose 3 months because that happened to fit with our schedule for our follow-ups, because I don't think that anything acutely, and even the NIPS post-procedure of 24 hours doesn't mean anything, because it can still be transient effect. So I think it's still open, in my opinion. We have no idea to acutely assess what we have been doing with VT ablation. Of course, yeah.
Pasquale, can I just chime in? Yeah. And well, we also have a feeling, especially there are 2 European centers, and when we gathered a user meeting of Centauri PFA, we all share the same feeling. It works good for our idiopathic PVCs, but somehow we're a bit disappointed with a lack of better success rate, long-term success rate or mid-term success rate for structural heart VTs. And then we speculated really it's because we lost our endpoints, because non-usability at the endpoint doesn't mean that we get rid of the channels. And again, abolishing all the lavas, doesn't mean that we really ablated all these areas. But it really points out to the fact how important is our imaging, understanding of a substrate. And when we start using, I'm sorry, this is inHEART sponsored webinar, but we've seen a change when we started using 2 years ago, this kind of imaging and ablating irrespective of signals toward how as you progress in procedure. I think this will be a way forward. However, I speculate. I had a case last Tuesday. I speculated this case that at the end, the last VT morphology, could it be PFA induced? Could it be something transient? Some stubborn morphology that looked like the last pacing I had at the area. I'm also wondering, can we have it another way? Can we be confused in another direction, seeing that some VT morphologies that we have at the very end of procedure could be transient phenomenon due to some hyperpolarization of the states or transient increase in conduction or in some systems, whatever. We have to learn a lot.
Yeah, this pro-arrhythmia issue with PFA is also open. You're completely right. We end up seeing occasionally very low rate, but it's there, of these AIVR type of rhythms afterwards, 100, 130 beats per minute. And I ended up mapping one of these. It looks like focal automaticity from the border zone, in one case where we had to do it because it was happening despite drugs. And in fact, in the future studies that people are thinking about introducing a blanking period where you can actually increase drugs in the first 15 days to 20 days to manage these rhythms and then stop them. maybe you're right. It's an important problem, but which we have not seen before. I mean, with RFA, if you have VT the next day, it's a failure.
Yeah, to that respect, I'll just share, when we started doing, let's say, RVOT, PVC, we started doing ablation, we were confused by this irritated rhythm. We would chase them, and we chase and ablate them. And then after some time, we changed the workflow and said, look, let's start with a RF, let's suppress, and then we suppress, we bomb the area and move away, irrespective of what happens. And then we realized that in 90% of cases, they subside within the next 10, 15, or 20 minutes. Just leave them. And if you are very careful, you will see that there are some distinct morphologies, differences, and it's not exactly the PVC you mapped. If you use this matching software, it's going to be down to 93, 95, 94, 96. It will never come back to 99, 98% of matching, which is again important workflow adaptation when you think of ablating PVCs with PFA.
So since this is an imaging session, if we saw papers from Katja in the past about fat. We know that fat could interfere with PFA lesions. If you see intramyocardial fat on inHEART or you have major fat regions, would you go, both of you, for RF or PF in these regions?
I would go for both.
Yeah, I would think the same. Also because I don't think the PFA, we don't have data on fat actually. That's the problem. So we need to have, and it's very hard to create an animal model that reflects that. Maybe the LB Summit is the best, but I will also go for both.
I had a question about your comment, Pasquale, about going only PF in the epicardium, and maybe I missed something, but could you just elaborate on that? Why wouldn't you go RF with a catheter like Sphere 9 and why only PF?
So my major fear is the fact that it ablates all around the sphere. So you will be ablating. So typically when we ablate with a regular RF, we point our vector inwards toward the epicardium, and we try to stay away from the parietal, because there is some data from Bordeaux actually that if you do the other way around, you can injure the lungs and other things like that. So I think the same would happen with RFA with Affera, but it's impossible to bend it only one way unless you have fluid separating the parietal pericardium. So you end up ablating pericardial vessels, extra pericardial vessels. You can reach very high temperatures there. So that was my fear, and that's why I prefer to use PFA only.
So, but you agree that your answer, because it's an interesting question, it's then catheter related, because of course with the, for example, STSF catheter where you can clearly have your vector, and if you're sure, you would then do something else. So I think it's important for the audience knowing it's not because of the PF, it's because of that catheter that you use that ablates everywhere.
Absolutely true. Yeah, in fact, if I had access, which we don't have yet, to a dual energy STSF, I'll probably go with RF first, and then do PFA close to the phrenic and some other areas that I want to injure. So.
Ante, could you maybe comment?
Oh, sorry.
Could you maybe comment on the fact why you, above the aortic valve, that PF is not doing anything? Because you pointed it like that, but I, of course, want to understand why.
Benjamin, essentially this is what we expected, because the media of aorta is so hard to penetrate with anything. So I think what we've seen that the pulsed field ablation is bouncing away from these layers. It's because we have multiple layers of the tissue, very different tissue. And this is where PFA is very bad. As thermal methods, penetrate through continuously, PFA will bounce away as soon as it meets the other layer of the tissue, and with different impeditive characteristics. And this is why I had the redo LV Summit post RF, and we ablated with RF below the valve. Then I went to the left sinus of Valsalva, and then we had this recording. We are ablating with PFA, nothing happens. We just switched the cables because it was a Centauri. We just switched the cables within 4 seconds RF. It suppressed the PVCs. So this is my, is it going to be with other platforms? I will say likely. However, the jury's out there. However, currently we are not ablating above the semilunar valves. We are not ablating with the pulsed field ablation because of that no idea that it cannot penetrate through.
Ante, could just for the U.S. Folks, we don't really know much about Centauri. Maybe you could describe, is this just a separate company that can connect to any catheter? What is Centauri?
It was a great project started in 2020. An idea was to democratize the PFA. The idea was to create a pulse field ablation generator that can be operated with any catheter you want to use. So we tested in a ClipSafe trial, and it's published. We tested it. We tested it with a Tacticat sensor enabled. We tested it in the stable point, and we tested it with Navistar Smart Touch, non-SF. So it's also only 6 holes. These were the catheters that which we tested, and then we are using it in our everyday practice. There are more than around 35 centers in Europe. Unfortunately, it's never been marketed because that event transition now it's cardio focus, and it has never been marketed in US. I've always felt sorry for US physicians that they didn't have also for the technology that was not tested in US ground. It would probably fare much better on US ground than it did in Europe.
Thank you for that.
One question to the group we received, have there been any data on PFA and procedural efficiencies, table time, length of stay?
I may answer this for VT, right? I guess this is because of
Yes.
VT. Yes, I mean, our average procedure time is about 3 hours, 2 to 3 hours. So that's historically is much shorter than what we've been using for this very large substrate. Now we're getting even faster as we learn more how to use the catheter out, what the best, I would say, recipe of radiofrequency versus PFA in each different regions. But I think it's cut the procedure time by at least 50%, honestly, which is a great, honestly, we talk about efficacy and safety, but this is really an important endpoint, in my opinion, for VT, because you have less irrigation, less time under anesthesia. We do know that for VT, if you go above the 4-hour threshold, then the complication rate starts spiking afterwards. So I think it's an important endpoint for patients, procedural efficiency, just like it is for AF, honestly, but even more so for VT.
Pasquale, do you think that this lack of transmurality is dependent on the wavefronts, or because you have lack of how much contact you're giving? Because it always comes back for me. We said you don't need contact, you need a little bit of contact. It is really annoying that we say it here, but it's your data is so disappointing in a way. If it's just outflow tract, and even there we're not transmural.
Yeah. Well, the contact is there. The contact force is the problem, right? So we cannot push more than a certain amount with sphere 9, which is on one side is a safety, I would say, thing, because I don't think it's possible to perforate with a sphere 9. But I think what they have to do, they have to basically change a little bit or improve the PFA waveform to make it deeper, which is the depth is really not something that you need all the time. You only need it for certain patients, but right now we don't have it. I'm not very upset that the ARVC patient, for example, that ablated epicardially had normal endocardial electrograms, because really you don't have to create a transmural lesion when it's not necessary. I think for that case was good enough, but for the septal VTs, you really would like to do it transmurally. For the LV summit, you would like to be transmural. So there has to be a setting where you can go deeper when needed, which is probably 30% of the times, honestly. The remaining 70%, we're just fine with the depth that we got with RF, because that's how we've been working for many years. But if you can get the same job done in 50% of the time and less irrigation is a great, I would say, outcome from my perspective. So.
But we all agree with Benjamin. He's pointing out to the fact that we need dedicated PFA configuration. Obviously, what works in A doesn't work well in B.
And just for maybe for all the three of you, your ideal catheter that we don't have yet, is it a large focal catheter with dual energy with proven contact force that you can titrate voltage and RF? Is that what you want to have?
For the regular case, I comply. However, Pasquale showed that, let's say for epicardial case, I assume that the most fantastic case would be like imagine you having regular decapolar catheter, like steerable decapolar catheter, and you can choose where to ablate from. We want to ablate just from between 2 and 3 electrodes, 2 and 3, because we have interesting electrograms. You want to have a full line across the scar. This is already out there. You can ablate to a wire. You can ablate to a two French catheter, like a Lima-like catheter, like we used to be. And then we have large. And we want to have this opportunity to have ablate large area at less time. And for this, again, you have multipolar catheters, but with field medical, it has been shown that you can do very large area ablation within a matter of a second. However, how safe is that? How to titrate that? How to avoid collateral injury? How to avoid infringing damage to a healthy myocardium, and thereby endangering your patient and lowering down the EF? That's down the road that we have to assume, and we have to research.
I think being able to titrate your lesion depth based on your, it's similar to the short point index, lesion size index that we currently have, between contact force and then maybe the number of applications you can toggle and dial up or dial down the number of, I think we're lacking in terms of that. The catheter technology is moving so fast that every 6 months we have a new catheter in our hands, and we don't have enough time to learn and develop maybe that function of depth.
Also, bear in mind, in future, we're going to have ability that you can swap. You're going to have your solid tip catheter. You can do regular monopolar PFA with it. But if you want to switch to the bipolar PFA, but the bipolar that is tailored, so you can put one catheter on one side of the septum, and you can have your regular ablation of your septum, and you can do this in between to tailor your bipolar PFA. This is the future. It's going to be fun.
Yeah, and I can add also my ideal catheter is something that you can also map from it with high resolution. So because we don't really like to do the exchange that much any longer. So we do a single solution where you map quickly, you ablate quickly, and you get out, honestly. And that's probably one of the major advantages of Affera these days.
I think we're at the top of the hour. I don't think there's any other questions. So, Isabella, if you'd like to wrap up, thank you to everyone.
So, thank you to our presenters and guest panelists for your time and for sharing your experience with PFA for ventricular tachycardia. To all our attendees, thank you for joining us. And if you have additional questions, please reach out to us at sales@inheartmedical.com. We'd also love to connect with you in person, so you can find us at ERA Conference in Paris, April 12 to 14 at booth E400, as well as FHRS in Chicago, April 23rd, 26 at booth 528. To watch videos from previous inHEART webinars, please visit inheartmedical.com and select resources and then webinars from the main menu on the top right of the screen. Thank you everyone and have a great day.